It is my great honor to introduce Dr. Lori Wirth as our distinguished speaker today. I was privileged to hear Dr. Wirth speak of her exciting work treating advanced thyroid cancer when she was the guest speaker at the Atlanta VA Medical Center Quarterly Endocrine Conference earlier this year. I learned so much from her talk, including hope for some of our sickest thyroid cancer patients and their families. Dr. Lori Wirth is an associate professor in medicine at Harvard Medical School and joined Mass General Hospital in 2008 to become the medical director of the Center for Head and Neck Oncology. Dr. Wirth attended Brown University as an undergraduate, then obtained her MD from Columbia University College of Physicians and Surgeons, where she had the distinction of being nominated to the AOA Medical Honor Society. Dr. Wirth was a fellow in hematology oncology at Harvard's Dana-Farber Cancer Center and with the Mass General and Brigham Cancer Center Fellowship Program. Dr. Wirth was on staff in head and neck oncology at the Dana-Farber Cancer Institute in Boston. She is a leading authority in head and neck cancer oncology with special expertise in combined modality therapy for cancers of the head and neck and new treatments for advanced thyroid cancers. She sits on national and international committees that guide cancer treatment and research efforts. I greatly look forward to your talk today and welcome virtually to the Winship Cancer Institute in Atlanta, Georgia. Thank you.
I am Lori Wirth, and I am going to be talking today about targeting RET in medullary thyroid cancer. Dr. Chen, thank you for inviting me to join your meeting, and I look forward to the live part of the meeting. Here are my disclosures. I'm going to be talking about medullary thyroid cancer today. While it only accounts for 3% of all thyroid cancers, because of the poor prognosis with medullary thyroid cancer, it accounts for more than 3% of thyroid cancer deaths. Now, 25% of all medullary thyroid cancers are familial, seen in the MEN2A and MEN2B syndromes. All of these patients harbor germline RET mutations. But of the 75% of sporadic medullary thyroid cancers, approximately 60% of these patients harbor somatic RET mutations. So RET drives a majority of all medullary thyroid cancers. RET encodes a transmembrane receptor tyrosine kinase. It's expressed in the CNS and development of the enteric nervous system. It's also expressed in perifollicular C cells, hematopoietic stem cells, and in spermatogenesis. And RET signals via multiple kinase pathways, including the MAP kinase pathway, PI3 kinase pathway, the JAK-STAT pathway, and so forth. Now, there are an array of RET mutations that are seen in MEN2A and MEN2B, shown here in this chart, and many of these mutations are also seen somatically in patients with sporadic medullary thyroid cancer. RET M918T is the most common somatic mutation that we see. That's in the kinase domain of the gene, and RET M918 mutations also drive most of the cases of MEN2B. The RET C634 mutation in the extracellular cysteine-rich domain of the gene is the most common hereditary mutation seen in MEN2A, but RET C634 mutations and other extracellular cysteine-rich domain mutations can also be seen somatically in patients with sporadic medullary thyroid cancer. Now, there's an interesting genotype-phenotype correlation in MTC. For example, the RET M918T mutation, when it occurs sporadically, it does lead to more aggressive disease than as compared to other RET mutations that occur somatically. But also the MEN2A and MEN2B mutations give rise to various levels of risk of the incidence of pheochromocytoma, hyperparathyroidism, cutaneous lichenoid amyloidosis, and also Hirschsprung's disease. But also it's important to know that the various mutations give rise to different risk levels for the age of onset of medullary thyroid cancer. So the mutations that have a moderate risk level for the age of onset will give rise to MTCs later in life, whereas the high-risk mutations give rise to MTC in childhood, and the highest risk mutation, RET M918T, seen in MEN2B, gives rise to medullary thyroid cancer even within the first 1 or 2 years of life. And the reason why that's so important is because patients that are at risk for harboring these germline mutations need to be genotyped early in life so that they can undergo a prophylactic thyroidectomy before they develop medullary thyroid cancer. Another interesting aspect of the genotype-phenotype correlation is shown in the pictures below. This is a patient of mine who very graciously gave me permission to use her photographs. She has MEN2B, and in addition to MTC and pheochromocytoma in these patients, they also have a marfanoid body habitus with a long facies, as you can see here in this patient, and mucosal ganglioneuromas, as seen here in her lips, her tongue, her conjunctiva. And that CT scan shows that she's undergone a bilateral adrenalectomies because of the development of bilateral pheochromocytomas. So RET was first identified as a transformative mutation in NIH 3T3 cell line in 1985. It was first identified as an oncogenic fusion by Fusco and colleagues in papillary thyroid cancers in 1987. And then in the early 1990s, Santoro and Donis and Keller identified RET mutations in families with MEN2A and MEN2B. Massimo Santoro first studied vandetanib, a RET VEGFR multikinase inhibitor, in his CTC cell lines in medullary thyroid cancer, and that led to the study of vandetanib in patients with medullary thyroid cancer, and the first FDA approval for in the modern era for a drug for MTC in 2011. Cabozantinib was approved by the FDA in 2013. So cabozantinib and vandetanib are multikinase inhibitors that inhibit RET as well as other kinases, including VEGFR2. These kinome dendrograms here show the kinases that are inhibited by cabozantinib, vandetanib, and other drugs with RET activity. The multiple balls represent the multiple kinases that are inhibited by these drugs. The balls are color-coded for which kinase is inhibited, and the size of the ball represents the degree of the kinase inhibition in these kinome dendrograms. So I mentioned that vandetanib was FDA approved in 2011 on the basis of the ZETA trial that showed a significant improvement in progression-free survival with vandetanib compared to placebo and an overall response rate in MTC of 45%. And cabozantinib was FDA approved a couple of years later based on the EXAM trial, showing again a progression-free survival benefit with cabozantinib compared to placebo and an overall response rate of 28%. Now, these VEGFR multikinase inhibitors, while efficacious, do cause adverse events that our patients have to contend with. Hypertension, hand-foot syndrome, diarrhea, anorexia, weight loss, nausea, fatigue are some of the most common adverse events that we see. These are generally managed with dose holds, dose reductions, and supportive care, but do occasionally lead to the permanent discontinuation rates of 12 and 16% with vandetanib and cabozantinib, respectively. So I think what happened in the field was once we realized that there are adverse events that can impact on quality of life, rather than starting a TKI as soon as possible, we swung away from that and started holding off on starting TKIs kind of for as long as possible because of this adverse event profile that our patients have to contend with. So getting back to the timeline, now in 2012, the KIF5B RET fusion was detected in non-small cell lung cancer. And I think that detection of the RET fusions in non-small cell lung cancer led to the pharmaceuticals' interest in specifically targeting RET in terms of developing RET-specific inhibitors. The first trials were launched in 2018, and then in 2020, selpercatinib achieved the first RET gene-specific approval by the FDA, and then in 2021, pralsetinib was approved shortly thereafter. So pralsetinib and selpercatinib were both designed very similarly to potently and specifically inhibit RET and have as little off-target activity as possible. They were both designed to inhibit the wild-type RET kinase that we see present in fusions in non-small cell lung cancer, but also papillary thyroid cancer, as well as all of the known oncogenic RET mutations that we see in medullary thyroid cancer, including RET V804 that we now know is a gatekeeper resistance mutation. So both of these drugs were designed to inhibit the emergence of resistance right from the get-go. They were also both designed to have as little activity as possible against VEGFR2 or KDR, with the idea that the efficacy of the other RET MKIs is probably limited by insufficient RET inhibition because of the off-target toxicity from inhibiting KDR as well as the other kinases. So the Libretto 001 trial was the first-in-human open-label phase 1/2 trial investigating selpercatinib in RET-driven non-small cell lung cancer, RET-driven thyroid cancers, and other RET-driven cancers. 746 patients have now been reported. I'm going to show you the updated data from the three thyroid cancer cohorts. Here we see the waterfall plot for selpercatinib in previously treated patients with medullary thyroid cancer who had received prior cabozantinib, vandetanib, or both. Eric Sherman presented these data at ASCO earlier this year. We now have reported 143 patients in this cohort of previously treated patients, and by blinded independent review, we see an objective response rate of 69% in these patients, and we're even seeing complete responses in these patients. Now, the bars are color-coded for the various RET mutations enrolled, and as expected, RET M918T was the most common mutation that was enrolled. We see responses across all of the RET mutations, and including in those green bars representing patients with the gatekeeper resistance mutation, RET V804. This is the waterfall plot for the updated 112 patients with cabozantinib and vandetanib naive medullary thyroid cancer. The objective response rate in this patient population is 71%. Again, we're seeing a number of patients with complete responses. The median PFS for both cohorts has not yet been reached, and the one-year PFS rate for this cabozantinib and vandetanib naive patient population is 93%. Here we see the waterfall plot for 34 patients with RET fusion-positive follicular-derived thyroid cancer. In the previously treated patient population, the objective response rate is 77%, and in the systemic therapy naive patient population, the objective response rate is 92%. Now, as the drug was designed, we are indeed seeing a relatively well adverse event profile with selpercatinib. The table here shows the adverse events that were seen in the RET-altered thyroid cancer patient population. The most common adverse events that were grade 3 or grade 4 were hypertension, increased ALT and AST, hyponatremia, and diarrhea. 30% of patients on the trial did have dose reductions due to treatment-related adverse events, but only 2% of patients had to have discontinuation due to treatment-related adverse events. Most of the adverse events that were seen were grade 1 or grade 2, and most of the adverse events were indeed reversible or manageable. And it was, of course, on the basis of the Libretto 001 data that selpercatinib was FDA approved for the treatment of RET-driven non-small cell lung cancer and RET-driven thyroid cancers. Here I want to show you a brief case. This is a patient of mine with a hereditary germline mutation at RET V804, that gatekeeper resistance mutation. This is a 57-year-old man at the time that he enrolled on the selpercatinib trial. He had been heavily pretreated with cabozantinib, vandetanib, and lenvatinib. He had progressed on 2 of those drugs, and lenvatinib was discontinued due to toxicity. He started selpercatinib in the dose escalation part of the study and was ultimately escalated to the recommended phase 2 dose of 160 milligrams BID. But even prior to the dose escalation, within the first 2 months of treatment, he achieved a complete response to selpercatinib. As you can see in the MRI of the liver, showing a diffuse infiltration of disease in the liver that had entirely resolved after 2 months of therapy. His calcitonin and CEA levels dropped, and when this slide was first put together, he remained in response at 9 months in July of 2018. So, as I mentioned, he enrolled in 2017. He experienced a very rapid, complete response radiographically and with his tumor markers. He remained on the Libretto 001 study, and in February of 2021, selpercatinib had to be held because he underwent a right total hip arthroplasty. Now, this was complicated by infection, so selpercatinib remained on hold until late April of 2021. And I was very afraid that his disease was going to recur during that time, but it didn't. So his calcitonin and CEA levels remained normal. And as you can see in these tumor measurements, this gentleman remains in complete response, even after the drug was held for 2 months. In terms of future directions, one important study is the Libretto 531 study. This is now enrolling, and Libretto 531 randomizes patients with progressive medullary thyroid cancer harboring a RET mutation to either selpercatinib or physician's choice vandetanib or cabozantinib, with a 2-to-1 randomization weighted towards selpercatinib. And the primary endpoint of the study right now is a composite endpoint of progression-free survival, as well as treatment failure-free survival. I'd like to point out that this trial is open to enrollment internationally and is allowing enrollment of even children 12 years and older. This is going to be an important trial that will look at the PFS as well as sequencing of therapy. Patients who are enrolled in the vandetanib cabozantinib arm at the time of progression will cross over and receive selpercatinib. Now, the ARROW trial was a similarly designed phase 1/2 trial investigating pralsetinib in RET-driven cancers. I will show you the data for the 3 thyroid cancer cohorts of RET mutant medullary thyroid cancer with prior vandetanib or cabozantinib or both, MTC without prior systemic therapy, and then there was a small number of patients that had received RET fusion positive thyroid cancer as well. So here we see the waterfall plots that were recently published in the Lancet Diabetes and Endocrinology. The overall response rate in MTC patients that had been previously treated was 60%. The overall response rate was 71% in patients with MTC that had not received prior systemic therapy. The median progression-free survivals for these patients had not yet been reached at the time of the reporting, but the 1-year PFS rates are very promising at 75% and 81%. And then in the 21 patients with RET fusion positive thyroid cancer, the overall response rate is 89% with a 1-year PFS rate of 81%. The safety profile of pralsetinib is shown in these charts here. The most common treatment-related adverse events that were grade 3 or 4 included AST, ALT elevations, leukopenia, neutropenia, and 46% of patients did have to have dose reductions, but only 4% of patients had dose discontinuation. Again, most of the adverse events were grade 1 and grade 2. Most of the adverse events, also similarly to selpercatinib, are manageable or tolerable. And it was the ARROW trial that led to the approval of pralsetinib in RET-driven non-small cell lung cancer and RET-driven thyroid cancers. similar to the Libretto 531 trial, the Accelerate MTC trial is a randomized phase 3 trial that is now underway investigating pralsetinib versus standard of care treatment cabozantinib or vandatinib in RET-mutated progressive medullary thyroid cancer with a primary endpoint of progression-free survival. This also is an international multi-center trial. So getting back to that idea of the pendulum shifting, I do wonder now that in this gene-specific era, when we have drugs that are highly potent and specific, have good activity and better side effect profiles than the multikinase inhibitors, do we want that pendulum to swing back to earlier therapy? I'm not convinced that later therapy or holding off on starting these drugs as long as possible really is the best approach for our patients with thyroid cancer. We really don't do this in other solid tumor settings. And so I think that that's a really important question to ask. Now, we are beginning to explore selpercatinib and pralsetinib earlier in the course of thyroid cancers, for example, in taking a look at neoadjuvant therapy for patients who present with bulky RET-altered thyroid cancers. And then I'm hoping that we might even begin to explore these drugs in when we have patients with MTC who don't have structural disease that we can see on CT scans, but we know that they have disease with rising calcitonin and CEA levels. Those patients that have rapid calcitonin and CEA doubling times, we know are at risk for dying of MTC. And can we change that with earlier initiation of therapy? I think that that's an important question. And then also, I'm wondering, with earlier therapy, when patients have a lower disease burden, can we actually get more bang for the buck in starting these drugs earlier? Can we ward off acquired resistance by starting therapy earlier? The reason why I ask that is because we are unfortunately now seeing the emergence of acquired resistance. So even though selpercatinib and pralsetinib were designed to overcome acquired resistance at RET V804, it still is possible. So this other case is a patient of mine with sporadic medullary thyroid cancer that had an extracellular cysteine-rich domain deletion. He was enrolled on Libretto 001 in September of 2018. He achieved a partial response to therapy. This lasted 43 months until April of 2021, when he developed new and enlarging liver lesions. We sent off a liquid biopsy in this gentleman, and it showed the somatic mutation that he had initially, but we also saw an acquired RET G810 mutation. This was confirmed on liver biopsy, and vandatinib was started. So what we now know is that the RET G810 mutations are being seen in patients who develop acquired resistance in patients treated with lung cancer and thyroid cancer with pralsetinib and selpercatinib. This is a conserved solvent front mutation that's paralogous with other receptor tyrosine kinases that target ALK, TRK, and ROS1. Mutations at this solvent front has led to acquired resistance with other TKI therapies, and now we're seeing it with selpercatinib and pralsetinib as well. And what structural modeling has shown is that mutations at RET G810 lead to bulky charged polar residues that interfere with the drug binding in that ATP binding site. So that's a mechanism, that's one mechanism of acquired resistance that has now emerged. But other mechanisms have now been described as well. So this chart here shows a number of RET acquired resistance mutations that we have seen emerge in RET-driven cancers with RET-targeted therapy, including the multikinase inhibitors, cabozantinib and vandatinib, with the V804 that I've mentioned, as well as an S904 mutation that arises in the activation loop. Then with the RET-specific inhibitors, we're seeing not only the solvent front mutations at G810, but also hinge mutations emerging at RET Y806, and mutations have also been described at Y738 in the beta-2 strand. Other bypass mechanisms have emerged as well, including MET amplification and KRAS amplification. So knowing these acquired resistance alterations, we now can get smarter in treating patients. Of course, we have to do the clinical trials first. For example, TPX-0046 is an agent that's now in the first-in-human study that was designed specifically to overcome the solvent front mutation at RET G810. So I'm going to wrap things up. Let me just say that RET mutations do drive a majority of medullary thyroid cancers. All patients with germline MEN2A or MEN2B syndromes, of course, but also a majority of patients with sporadic medullary thyroid cancers. The VEGFR RET multikinase inhibitors do have activity, but the side effects are impactful. And the RET-specific inhibitors, both selpercatinib and pralsetinib, are highly efficacious with a favorable side effect profile. Precision medicine is now an established treatment paradigm in thyroid cancer. Randomized controlled trials of RET-specific inhibitors versus the multikinase inhibitors are now underway. The PFS outcomes of these studies are very important, but I also think that the question of sequencing of these therapies in these phase 3 trials is very important. So, if we have a patient who's treated with first-line cabozantinib and develops acquired resistance at RET V804, we know that selpercatinib or pralsetinib will be efficacious in those patients, as represented by these liver MRIs here of a patient of mine who was enrolled in the selpercatinib trial. But is the case going to be the same if patients are treated with selpercatinib or pralsetinib first and then develop acquired resistance? Will those patients respond to second-line VEGFR multikinase inhibitor? That's an open question and a very important question for our patient population. Also, I think it's important to know if earlier initiation of RET-specific therapy will improve outcomes for patients with medullary thyroid cancer in terms of neoadjuvant treatment, improving surgical outcomes. Will earlier treatment delay the emergence of acquired resistance when there's less bulk of disease? And even, is there a chance for cure for these patients? And with that, I'll wrap things up and say thank you very much.